I have control.
Good.
Right. So let's go. Screen sharing. Let's have a look. A little wander. Now, Dupuytren's mean a lot to you? Do you see anything in the way of Dupuytren's?
Yes. Yes, I don't see it on a regular basis, but I was asked to gather about 30 different participants for a study, and I needed to image them. So I read up on it entirely. So I'm very eager to see what you have to show here.
Yeah. This, you see, okay, have you got it on the screen?
Yes, I do. I have a good view of it.
This is just a short clip of a very, very thick bit. You don't normally see it this large. And if you put your eye on the tendon there,
yes,
short axis in the palm, and you see the swelling here. It doesn't look like much, but if you go back, you'll see that it grows out of almost nothing. Yeah, and then it carries on, and that's it in long sections. So you've got the tendon there, but then you've got this dark mass above it, but it's continuous with the fascia that's running through the palm, and often you see it sort of blending with the underside of the dermis. So it'll come from the on a high spec machine, you'll actually see the fibers come off palmaris longus if they've got one, and you'll be able to follow the palmaris longus as it disperses into the palm, and then you'll pick up on one of those threads. It will suddenly thicken up and will actually join up and attach to the fascia that forms on the bottom of the underside of the dermis, and that's quite a normal pattern to see in Dupuytren's. I think this may even be the same case. It certainly looks very similar. I don't actually think it is the same case. But let's have a look. Yeah, you see it, just these little changes. So it's quite subtle. That's going into long section, and you see how it's sort of fusiform, and with the eye of faith, you can see it blends with the tissue round there.
No, so you're doing a good job of explaining it. I just wished I understood the pathomechanics of it evolving. Is it just like a burrow in a tree? Are they predisposed to throw out random collagen, or does it seem like it has any correlation to overuse, or is it just hereditary? I don't know that.
I think it's just hereditary. It's or certainly there's a big hereditary element. It's your classic Viking gene, isn't it? Doesn't really occur in other populations to the same extent, and it's very closely related to frozen shoulder. In fact, occasionally frozen shoulder actually looks the same.
What about fibromatosis on the plantar surface, or any kind of an ectopic, collagen buildup that isn't along the strands?
Yep, that's the fibromatosis. You see, looks very similar, just on a grander scale. This is a giant cell, or I think it's likely to be a giant cell tumor. I think this was called a ganglion. Somebody in radiology miscalled that as a ganglion, but I hope you can see that it's got solid content.
And that's where there's that level of confidence in you can't be ganglion because it's not anechoic or it's not black. Yeah. It has some level of content. Do you push down on that, or do you just say, Greg, I can see it's complex?
Like pretty much, you get used to it on your scanner what they look like. Gotcha. Now just the grayscale echo texture, you would still, depending on where it is, you would still consider that it might be a what's the word for it? A sebaceous cyst or something like that can have this texture, but it wouldn't have any color flow in it. And that's why you can see when I'm doing the color test, you can see jelly over the top of it.
Yeah.
And you can see the pulse repetition frequency is very low. So I'm really looking for low flow at this point.
Pulse repetition frequency is how frequent it sends out its carrier wave to determine whether there's a different phase in what the frequency is that returns, and it's 3 times a second?
Yeah, 3 centimeters per second is the way they measure it. I can't quite remember how the calculations work, but basically it makes it very sensitive to low flow, but rubbish at depicting higher speeds, which just come out as a mess. But as we're only interested in low flow, we're looking to tell the difference between solid and vascularized lesions. So we're just
now is the giant cell, is it predisposed to any type of histology, or does it exist on its own accord? I mean, unlike a neuroma where we would.
It's the giant cell is related to things like PVNS. So it's a proliferative lesion of the of synovial tissue.
Oh, okay.
Now that is about as far as my knowledge goes. This is one, I think you'll have seen it because I put this one on the Tinternet, on Twitter. So this was a little bit of synovitis here, short axis on the second MTP joint. Yeah. But what offended me is what it looks like just beyond it. So if you look at this is the MTP joint of number 3.
Yes.
Which isn't inflamed, but what happens afterwards, that goes to normal tissue. This side, when it goes away, goes to this bright tissue here.
Yes.
Yeah, that's bright. The tissue around the other next metacarpal, metatarsal is not. That's normal fat appearance and maybe some muscle there. This is bright, fatty, reactive tissue, which you don't typically see a lot of in just a typical inflammation of a joint. But if you have an infection, then you get this. And I think some of the sports med people say, oh, we see that in stress fractures, and you do. But you also see a little fracture, typically, or sign of a fracture. When you don't see that, and when the history isn't right for that, then you have to think osteomyelitis, or you should think osteomyelitis.
Wow, you have gone through such physiology as to, you're talking about, as we back up to trauma, the actual weepage of fatty material from the fracture itself brings the fat to
no, this is just the reaction you get in fat when there's inflammation.
Okay, so it's just a reactive response on the part of the fat that's in the region if there's a fracture.
Yeah, if there's a fracture. But when the story isn't right for it, this should make you suspicious of something else pathological going on that is causing a reaction in the surrounding fat. And you'd always look at that whenever you look at the
circle again the hyperechoic region you're talking about, that whole area around that, as opposed to on the third one, we're looking at actual a structure. You said like a lumbrical like muscle or something like that in that region.
Might be a bit of muscle. I think it's just fat that's a different texture. But
okay.
But the things you see around here, you'll sometimes see little bits of muscle, but the fat, you see, that's all very natural, healthy-looking fat there. That is not, and it doesn't look like much. You know, when you scan through it, you'd miss it because the big pathology you can see here in the joint. But actually, that could just be any old inflammatory joint change. This is something different. This ups the ante as to what is going on.
Wow, that's really valuable. It looks like there's a cloudiness that surrounds it like a helmet around the whole region.
Yeah, it suggests that the inflammation isn't just related to the joint, but related to the bone itself.
And would we expect a metabolic reactivity of hyperemia or any kind of neovascularity around that, or is that
not necessarily? You'd see that at the joint. You might see that in the surrounding fat, but you don't have to. And particularly with a case and the ones I pick up that are missed are not obvious on X-ray, and they're grumbling. You know, I've had them that have been around kicking on for 2 years. So you don't always get this story, which is how it gets overlooked. They're kicking on for a long time. They're just painful. The infection isn't enough. They don't become septic or anything like that. So and the body's just fighting it all the time. But these are really dragging on, and very easily overlooked. So that was that. Achilles rupture. This was 2 months, I think, after it happened, and probably happened in 2 stages. So here you've got, and I didn't spend a lot of time looking at it because it was a ruptured Achilles, but they've also ruptured their medial gastrocs up at the top. But
with fatty infiltration in that muscle.
This is 2 months down the line, and they've also and they've gone on to rupture their Achilles. So this is the distal Achilles, and you can see that characteristic super swelling of it coming all the way down from the insertion, which is what you see at your distal, and not going straight. So that straight away, that tells you it's ruptured. And there you're coming up, and there you see the the end of it. This is 2 months down the line and not been picked up, or not had anything done about it. So you get all this mass in there, which is just fibrotic tissue. And then this is the there.
That's the proximal stump. Is that what you said?
Yeah.
Wow. So they came in. What made you even? Did somebody say, "Hey, I think they have pain in the back of their calf," or what?
I think in this case that the GP said, and that people are presenting really late at the moment. So there's a bit of a gap in the thing. His ambiguous testing. Have a look, see if they've injured their Achilles. Query partial tear is what they say, and then you look and straight away, these are old men. They don't have a lot of dorsiflexion naturally. And so when you see a nice athletic dorsiflexion in the no. That's just healed long.
And he was saying, look how far forward I can lean on.
Yeah. That's going to really help your skiing, isn't it? They're going to get there. I think I showed you this last time. I wasn't sure what you'd seen before when I was picking cases out before we started.
Man, that looks like an anemone under our docks here down at the bottom. That's kind of moving around. No, you didn't show this to me. What is that, John?
Well, you tell me then. And it's only a short clip. But
I don't have a clue. I mean, I can see some vessels. Like I see
abdominal
a very
wall, abdominal wall. These are probably the inferior epigastric vessels, and this is an ascites, and that's a loop of bowel.
My land, John.
So that's fluid filling the tummy.
Yes.
And a little loop of bowel. Let's see, they're the Dupuytren's cases. Sorry, we started on them. Not quite sure why. Have you ever seen a female femoral hernia?
No.
Well, that's often what they look like.
Remember, I don't know what hernias look like. I try to have as many visits with you as I can, and I don't seem to be any smarter, though I haven't spent a lot of brain time on it.
Well, I'll skip through that one. So and sometime when you start looking at them, we'll get to that. This was I have not imaged this particularly elegantly, but I will go through it because it was an interesting case. So this is the track of the sural nerve, which follows along with the short saphenous vein between the heads and gastrocs.
Yes.
So you've got your sural nerve there, and this ganglion sitting there is pressing on it. Here, there,
Point.
you can see the nerve nestling in the gap.
Yes. Yes.
The vein is there, not being shown very well, but the ganglion is going to come into view there. Yeah?
Yes.
We've only got a short clip there. That nerve being pressed there. Let's have a look. This is a Garrod's pad.
I don't know where that is.
Yeah, and it's and you won't enjoy looking at the picture either because there's very little to see. I'll just but it's one of those things you'll get asked about, and everyone will think it's a cyst. This is the PIP joint.
Yes.
And this is, you can just about make it out, the flexor, the extensor mechanism. And then you get this little squish just under the skin. And the patient complains of a little lump sitting on the top of their finger.
Yes.
And when you scan them, you don't really see anything until you look really carefully. And then there's just a tiny bit of thickened tissue here. And it's called a Garrod's pad.
Can you spell the first word? G-A-R-R?
G-A-R-R-O-D.
Garrod pad.
Yeah. And there's just really not very much to see. They're just tiny little thickenings. And you want there to be a ganglion there, but there isn't.
Yes.
It's just a little bit of thickening tissue and associated with rheumatoid, but doesn't prove it. This is a nice, if it's the one I remember, a nice inguinal hernia. So I'm here, lined up in the groin along the crease, roughly, maybe slightly above it. And you see, if I stop it, because it goes through a bit quick if your eye's not used to it. But do you see those loops? These are loops of bowel.
I can see the loops.
Yeah.
I wished I could see the bowel, but
that is the bowel. That tubulous thing running through with all the fat. So it's fat here going through, and then a piece of bowel. There's the bowel wall. These are the lining of the bowel wall.
Can you name the fascia, or tell me where the fascia is? Is that inguinal region?
Yeah. This is long section on the inguinal canal.
So okay, I'm with you.
Lower level, and that's
okay.
The top level. And I usually try at the end of a clip just to show, but I think I was just there. Oh yes, there you go. There are some blood vessels there, possibly the inferior epigastrics, but it should really go over the top of them. So
what's the densities in that dark area? Is that feces?
That's maybe a little bit of feces. There's a little bit of air, these bright things.
Okay,
Might just be a little bit of windy pops collecting in there.
Okay.
What's this one? This is, oh yeah, this was up in the foot, up in the upper arm. The patient had a swelling on their biceps. And if I bring this back, because it jumps around a bit, let me just bring it back. So you've got, I think that is the short head and that's the long head of biceps. And you see the fat in between?
Yes.
And that's a big lipoma.
I can see it now.
Yeah. And but you have to almost believe that it's there and then play with the anisotropy to get the contrast between them, because it just otherwise it just looks like normal muscle. You know, what you
just said is so powerful to understand. You simply do the slice, and if it doesn't show up in a way that is differentiatable, you play with the actual angle of incidence until you can actually differentiate the fibers of the fascicular muscle from the fat of the lipoma.
Yeah.
Wow.
Because the fascia is fairly randomly or sort of distributed around. Now, this is something that we pick up from time to time. Often they come in because people think they have a trochanteric bursitis on the
Yeah,
side.
is this at the iliac crest? And
Yes.
this is the iliotibial band stuff. Those
Yeah.
suck, man. I have to try. I can't figure out how to treat them other than doing stretches. And man, keep going. I'm listening to you.
Well, the guys like Shockwave, I think.
Yeah. Well,
I remember
me how
last
come-
one came in. I didn't know what to suggest, so I asked Chris Myers, and I think he said he shocked them. But you know, I presume they should respond to whatever a tendon does. You know, you just have to a bit of rest and a bit of thing. But you know, even therapeutic ultrasound, I think, would probably be reasonably. I know that's very untrendy, but
yeah, it's untrendy, but we can't get our hands on Shockwave here in the U.S. I have no idea why that's so that way, but yeah, that's really valuable to me.
Yeah, but do you see how it looks? You know, just
that's short axis at the rim, right?
Yeah, that's short axis at the rim. But
what
it's
is
one
that,
of those
John?
you just have to. It's easy to miss.
How would you name that? Would that be calcinosis, or would you just leave it be and say there's some periosteal degeneration?
I would just say there is some sort of, in inverted commas, tendinosis of the or fasciopathy of the thing, and you know, you treat it a bit like a plantar fascia.
Yeah.
Or at least think of it in that. So this is an interesting one. I'm going to play it for you and see what you think. I don't think you saw this last time. I was picking over case and I couldn't remember when I spoke to you last time, so I didn't know.
I did not see that. I'm again. This is elbow.
Yeah.
And this must be like RA or a really bad what do you call it? Elaborated synovitis of some sort, or is this? Exactly I don't know.
A colleague asked me to have a look at it, and that's what they thought, and I can see why. But I want to stop you there.
Yeah, okay. I wished I had better eyes at that.
Go ahead. Do you recognize this shape?
Yeah, that's the trochlea of the olecranon trochlea.
So follow the bone up, and what should you get there?
I don't know the answer to that, John.
It shouldn't end at a tip. Do you see how the bone ends in a tip there?
Yes. Oh, wow. That there should be a there's a fascial or a thickened ligament that's there.
No. But you should get bone. The bone should carry on. Bone doesn't end in a spike. Yeah,
help me with your thinking.
So this is the shape of the bone, but you usually you can see where my arrow is. So you get the trochlea, and then you get the epicondyle.
Straight away.
Yeah. So it's and bones have that shape. This comes to a point, and then it falls away, like some sort of mathematical curve.
Yeah.
So what is this?
We're medial there?
Yes, that's a soft tissue. That's where the medial epicondyle should be. Yeah, and that is soft tissue. So that's what metastasis looks like.
Is that right? And is it eroding the bone itself?
No, it is in the bone. It's replaced the bone there.
Unbelievable.
So look. So watch as you're scanning the. So you're scanning the bone there.
Yes.
And you see how the bone is replaced by soft tissue.
Wow.
But you won't see that until you've considered that, and that's and because the guys in musculoskeletal see so few of these, they're almost blind to it. So you have to look.
Wow.
And know that you've got to see.
So what you're looking at is your eyes are looking for the bright echo texture of the periosteal topography, and you say there's nothing there. There's no cancellous bone. There's no material there, and what we're looking at is a soft tissue with complex material in it when there should be a bony shadowing.
So that's what you should see, a bone going all the way around.
Yes, yes.
And then, you know, someone's taken a bite out of that apple.
Right.
Yeah.
My land.
So that's the one not to miss.
And you didn't.
No.
How? That's impressive, man.
Well,
and that was very active though on color Doppler as well, correct?
Yes.
Yep.
Yeah.
Wow.
But the difficulty my students have, coming from an MSK background, particularly from a physio background, is they don't think about it, and so they're thinking, you know, what's flashing, and they're thinking it's synovitis. Well, no, synovitis is in the joint, it's not in the bone, and you've got to trace that and see it.
Wow, that's very valuable, John.
That's a metastasis of some sort.
How much pain were they in there?
Quite a lot. But actually, the main thing was the swelling. That was what people expect to be in pain. They think they've got a sore elbow, and it's swelling. So you think there's going to be synovitis, but you know, you've got to keep your mind open. So hang on, how are we doing for time? You need to go to work.
I'm fine. If I have another 10 minutes, if you can give it to me, it's up to you entirely. But I'm sitting. My electric car just all of a sudden kicked into the gas mode. It turned on the generator, and I'm going, what's that for? And I realized my air conditioning has been using the battery power. So anyway, that's why I looked to the other. So keep going.
Now this is a very simple case, but we don't, certainly in my practice, I don't see it very often. So I captured a bit. This is the wrist joint, and this is the if I freeze that, this is the recess for capitate.
Okay.
And it has that very classic bell-shaped appearance.
Yeah.
So, but the synovium from the mid-tarsal joint should just run over the bone. And you see how here it's nice and clean, but it's swollen.
Yes.
And this is early onset of rheumatoid. This is the synovitis that you see at this level. And that's the shape that's the very characteristic shape as you scan over the capitate, and you get the swelling here. It doesn't have to just be there. You don't, that's not the only place you look, but that is very characteristic of an inflammatory arthropathy there. That shape there. Yeah. As opposed to, even if it's a bit arthritic, the shape will tend to follow the contour of the bone, whereas this goes the other way. You know, and that's classic wrist synovitis.
Oh.
And let's look. And lots of joint space. That one I'm pretty sure I did show you. Got radial fracture. No, I think we saw that one as well last time.
I don't remember that. I don't remember a radial fracture, John.
It's okay. It's not a great one, but and it's not been confirmed. But I was looking at a tennis elbow.
This is radial head fracture. Is that right?
Yeah.
Okay.
That can be radial head away. So I wouldn't leap up and say that's a radial fracture, but I was suspicious in this case that it was an occult, a previous one, not a recent one.
When you're looking at the capitellum there, and you're seeing all of that debris or that calcification, is that just OA that in your mind, or what is like all that?
This I think was actually, this was quite a complicated case, and again difficult to capture in a nice video. But eventually I thought that this was actually an avulsed lateral epicondyle.
Oh, okay. All right.
I couldn't see in this case a normal epicondyle.
Yeah,
So I wonder whether it
I've
was convulsed.
I've had that exact thing happen where there's been material like that right over the radiocapitellar joint, and I couldn't figure out whether it came from a compression fracture of the capitellum or whether or not it pulled off
Yeah.
of the lateral epicondyle. Interesting.
Yeah. So that was my best guess because the fibers ran very strongly into it, and I haven't shown it here well, but I couldn't really find a nice. Oh yes, this one is pure guesswork by me, so I don't know if it's true. But this was a patient.
We're at the shoulder.
Yeah, we're at the
Supraspinatus,
shoulder. We're
infraspinatus?
infraspinatus.
Yeah.
And this patient had really painful calcific tendinosis. And they turned up for a barbotage with me, and they said they were a lot better. And this is all I could see. And I think this is decompressed. I think this is it having gone away. And they're just left with this little dink in the this is infraspinatus coming round here.
Yeah.
And there's just this little bit of leftover stuff in it. So they had a little bit of pain, but I said, go away, come back if the pain doesn't go away, because you'll be fine.
So, John, as you take a look at the classic subacromial view of that, to what extent do you go then posterior view and internal rotation assessment of the enthesis of the infraspinatus? If you can clear it with one, do you always do the other to verify infraspinatus?
No, I scan infraspinatus in the same position as I scan supraspinatus. So I just put it in that karate punch position like this.
Yes.
Hand a little bit further down, I literally just in my old patients, I just literally have their arm resting on the back of the chair, but with the palm facing forward like that. That's enough. And if they're sore, they just lean back against the chair, and then it stops being sore. So and most shoulders you can get all the way around supraspinatus and infraspinatus just by that. I then move the arm this way and look at the back.
Oh, hang on. You said this way, but I'm having a bad view from here. Say it again.
Yeah. So I've scanned them in this position.
Yes.
Or on the back of the chair.
Yes.
If I'm struggling to see if I'm struggling to see infraspinatus, I often put the hand behind the back.
Okay.
Bring it round because
like a full crass. Like a full crass. Okay.
But I do that for infraspinatus rather than for supraspinatus generally.
Okay.
I look at supraspinatus there as well if I wanted on a bit of a stretch, but mostly some acromions just get in the way, and you can see a bit more of infraspinatus if you roll them round. So that's how I look at it. Where there's a big tear in supraspinatus, then the head comes up a bit, and then I'm looking at infraspinatus with the arm in this position, just because it draws it down and out from under the acromion.
And are you then going from the same position that you're looking at the posterior labrum and glenoid and the back of the humerus, and you're coming at the middle facet that way?
Yeah, and but then I go typically I go into short axis, and I try to follow it from round the joint. I pick up the tendon tissue round the joint line, and then you follow it up. And sometimes it disappears completely under the acromion, but you can often get, particularly if you put the arm right across here, you can often follow the infraspinatus round and try and get a view as to how much of it is torn. That's really what you're looking at. When you've got a big tear of supraspinatus, it's trying to figure out how much of infraspinatus is torn. And that has some relevance. I don't know how important it is. So that's what I do. This one.
What is this really quick? And then I'm going to need to run.
Yep, that's all right. This is a re-rupture of a supraspinatus. So there's a little bit left there, and you can just see the stitching.
Oh yeah. So I can see your short axis when I can see those little the sutures coming toward me. Okay.
Yeah, there. And it hasn't all ruptured, but there's a lot of it's gone. Okay. See you next time.
John,